Hey guys, and welcome back to the podcast. So, today we're starting with the brain because that is where many treatment plans either become executable or they collapse. A woman may know exactly what she's supposed to eat, when to move, which medication to take, and what labs really matter. But if she is chronically sleeping 6 hours or less, her brain may be operating with less attention, less emotional regulation, more fatigue, and then stronger reward driven eating cues. That's not a character problem. It is a biology, brain, and behavior problem. A randomized crossover trial in women gives us a clinically useful anchor here. Women who normally slept 7 to 9 hours were asked to restrict sleep by only about an hour and a half per night for 6 weeks. They were not selected because they already had diabetes. They were metabolically healthy enough to let the researchers ask one clean question. What happens when real world mild sleep restriction is imposed over time? The answer was not subtle clinically. Fasting insulin and HOMA-IR increased, and the effect on HOMA-IR appeared larger in postmenopausal women. This matters because many clinicians still treat sleep as a secondary lifestyle issue. Nutrition gets the plan, medication gets the plan, exercise gets a plan. Sleep becomes a thing that we mention at the end of the visit. But if sleep restriction can impair insulin sensitivity independent of adiposity change, then sleep belongs near the beginning of metabolic care. Now, through the B3 model of care, the transition is straightforward. Biology includes things like short sleep, circadian strain, sympathetic activation, insulin resistance, and then possibly inflammatory and appetite signaling changes. The brain includes reduced executive bandwidth, irritability, low frustration tolerance, higher craving salience, and impaired planning. Behavior includes things like skipped meal prep, reactive eating, missed movement sessions, and then the patient saying, I know what I need to do, I just can't make myself do it consistently. So the clinical mistake is to answer that statement with more information. The patient may not need another handout. She may need the plan matched to her current brain state. If the brain is sleep restricted, then the plan should become simpler, more cued, and more protective. One nutrient anchor, one movement anchor, one medication cue, one sleep boundary. That is not soft care. That is precision adherence design. For postmenopausal women, this conversation may be especially important. The trial was not large enough to make sweeping claims, but it did suggest a stronger insulin resistance response in the postmenopausal subgroup. Now, clinically, that should make us more curious when a midlifer or older woman says, her old strategies stopped working. It may not only be effort, it may be sleep, vasomotor symptoms, changing sex hormone, altered body composition, stress physiology, and then glucose regulation converging all together on her. Now, the supplement conversations should stay modest and symptom specific. So things like magnesium, glycine, L-theanine, these may help selected patients with sleep initiation or bedtime arousal. Protein and soluble fiber may support glucose stability. Vitamin D, B12, and iron should be addressed when they're deficient. Omega-3 fatty acids, these may support inflammatory and cardiometabolic resilience. None of these replace diagnosis, sleep apnea screening, or medical treatment. The question is always, what physiology are we supporting so the patient can implement the plan? So let's talk about the biology plan. This begins with assessment. Ask about sleep duration, timing, insomnia, apnea risk, night sweats, restless legs, pain, alcohol, caregiving, and shift work. Then connect sleep to metabolic markers. If the patient has rising fasting insulin, higher A1C, persistent cravings, or evening eating, sleep is not a side issue. It may be one of the drivers. And the behavioral plan should include a low capacity day. After a short night, the patient should not have to decide whether the whole plan is ruined. The low capacity plan might be take the essential medication, eat a protein forward first meal, walk 10 minutes, or do a gentle movement, avoid skipping meals, and then protect bedtime tonight. This keeps a patient in the treatment loop instead of turning one hard night into a week of disengagement. And the final takeaway here is this: sleep is metabolic medicine and adherence is medicine. When clinicians treat sleep as part of insulin resistance care, they stop interpreting behavior as laziness and they start designing plans that a tired brain can actually carry out. Okay, guys, I hope this little bit of information on this research was helpful and helps you the next time you have a metabolically unstable patient come in. It helps you to see where you need to kind of connect the dots and ask the questions. Ask the questions on their behaviors. Are they experiencing these behaviors? Because this will solidify your biological markers. And then always remember to look at the brain. What is going on in the brain of this person, especially in the cognitive load? What can be reduced to make the behavioral intervention more possible for them so that they can then feed back and correct the biology? All right, guys, I'll see you in the next episode.